Okay, let's talk about a situation that's incredibly time-sensitive. A patient whose heart is beating way too slow. In this quick guide, we're going to break down exactly how to handle symptomatic bradycardia, and we're going to focus on the number one first-line drug you absolutely have to know: atropine.
So here's our game plan. We'll start by figuring out what this emergency actually looks like. Then we'll introduce our solution, atropine, and get into how it works its magic. After that, we'll cover how to tell if it's working, what to do if it's not, and wrap up with the key things you gotta remember.
All right, first things first. Before we can treat anything, we have to know what we're looking at. Being able to spot symptomatic bradycardia and spot it fast is the most important first step.
So what are we really looking for here? Because it's not just about a low number on the heart monitor, right? It's about the entire picture the patient is showing us.
And here is the core of it. It's a two-part problem. You've got the slow heart rate, sure, but you also have significant, real, observable symptoms. If you don't have both, it's not the emergency we're talking about today. It's that combination that should make all the alarm bells in your head go off.
Now, the big red flags here, the ones you absolutely cannot miss, are those changes in mental status. Agitation, irritability, confusion. When a patient's heart is beating too slowly to get enough oxygen to the brain, these are the signs that tell you, hey, we have a major problem that needs to be fixed right now. Okay, so we've identified the problem, we see that slow heart rate, and we see the symptoms. Now, what's our go-to solution? Let's bring in the hero of our story today, atropine.
Let's be super clear about this. For symptomatic bradycardia, atropine is your first-line drug, period. It's the very first tool you should be reaching for to turn this situation around.
So we know what to give, but how does it actually work? Let's dive into the really cool way this drug does its job.
To get how atropine works, you gotta understand the two systems in our body that are basically in a constant tug of war over our heart rate. On one side, you have the parasympathetic nervous system, or PNS. Think of it as rest and digest. It's the brakes. It slows things down. On the other side is the sympathetic nervous system, the SNS. Your fight or flight, that's the gas pedal. It speeds things up.
And this is where atropine comes in. The best way to think about what it does is that it acts just like flicking a light switch. It's not a gradual turn of a dial. It's an instant flip from one system to the other.
And here's exactly how that switch gets flipped. Atropine works by blocking the vagus nerve, which is pretty much the main highway for that rest and digest system. By blocking it, you basically just turn off the PNS. You take your foot off the brakes. And when the brakes are off, that fight or flight system, the gas pedal just takes over, and boom, the heart rate goes up. It's really that simple.
Okay, so you've given the drug, but hey, we are not done yet, not by a long shot. Now comes the really important part, checking to see if what we did actually worked.
What does success actually look like here? How do we know for sure that the atropine did its job?
Listen, this is so important. You're looking for two things, not just one. First, you need to see it on the monitor. The ECG has to show a normal sinus rhythm. But just as important, you need to see it in the patient. Their symptoms have to get better. The confusion, the dizziness, all that has to go away. You have to fix the number and the patient.
Okay, let's put this to the test with a classic exam-style question. You've got a patient with a heart rate of 38, low blood pressure, and they're confused and dizzy. You give atropine. Now, which of these ECG strips would prove that the medicine actually worked?
Well, before we even glance at a strip, what's our goal? What number are we trying to hit? A normal heart rate is between 60 and 100 beats per minute. Our patient started at 38, so we need to get them up into that healthy range.
Now here's a super simple trick for getting a quick heart rate from a standard 6-second ECG strip. All you do is count the number of R peaks, the big tall spikes, and then you just multiply that number by 10. That's it.
So if we look at the ECG strip after giving the atropine and we count 8 R peaks, well, you do the math. 8 times 10 is 80 beats per minute. Is that effective? You bet it is. That is right in the sweet spot between 60 and 100. The medication totally worked.
But, in medicine, things don't always go by the book. We have to be ready for those times when our first plan, our go-to solution, just isn't enough.
So what happens if you've given the atropine and nothing? The patient is still bradycardic, still symptomatic, still in trouble? What's the backup plan?
The clinical protocol here is crystal clear, and you have to know this order. Step 1 is always atropine.
If that doesn't cut it, step 2 is an electrical fix, external pacing. That's where you use pads on the chest to electrically get the heart to beat correctly. Knowing that sequence is absolutely non-negotiable.
Phew, we have covered a lot of ground really fast. So, let's lock all this in. Let's do a rapid-fire review of the absolute most important points you need to take away from this.
Here it is, the whole thing in a nutshell. The problem? A slow heart rate plus symptoms. The solution? Atropine is your first move. How does it work? It flicks that switch from the rest system to the fight system. How do you know you won? You see a normal rhythm and the symptoms are gone. And your backup plan if it fails? External pacing. That's it.
So I'm going to leave you with this final thought. Knowing the protocol is one thing. That's the science. But the real art of what we do is seeing the trouble coming before it arrives. So how can you train yourself to pick up on those tiny, subtle signs, that little bit of irritability, that brief moment of confusion, so you can step in before